This is part 3 of our module, Drugs Acting on the Cardiovascular System, specifically agents for treating heart failure, which is chapter 44 of our reference book. Okay, the agents for treating heart failure is also known as cardiotonic agents. For our learning objectives, upon completion of this chapter, future nurses will be able to describe the pathophysiologic process of heart failure and the resultant clinical signs, explain the body's compensatory mechanisms that occur in response to heart failure, describe the therapeutic actions, indications, pharmacokinetics, contraindications, and cautions, most common adverse reactions, and important drug-to-drug interactions associated with cardiotonic agents, discuss the use of cardiotonic agents across the lifespan, compare and contrast the prototype drugs digoxin and inamrinone and digoxin's immune valve, outline nursing considerations including important teaching points for patients receiving cardiotonic agents. Before we proceed to the different cardiotonic agents, we will first have a short glimpse of heart failure. The heart failure, which is also called dropsy or decompensation. And this heart failure is a syndrome that involves dysfunction cardiac muscle, of which sarcomere is the basic unit. As mentioned in chapter 42, the sarcomere contains two contractile proteins, the actin and myosin, which are highly reactive with each other but at rest are kept apart by chemical troponin. When a cardiac muscle cell is stimulated, calcium enters the cell and inactivates the troponin, allowing the actin and myosin to form actomyosin bridges. The formation of these bridges allows the muscle fibers to slide together to contract. The formation of these bridges and subsequent contraction require a constant supply of oxygen, glucose, and calcium. So, this heart failure can occur in any of these orders: coronary artery disease or CAD, cardiomyopathy, hypertension, and valvular heart disease. We will elucidate a little the disorders that lead to heart failure. First we have there is the coronary artery disease or CAD, which is the leading cause of heart failure. It comprises 95% of cases. So this results in insufficient supply of blood to meet oxygen demands of myocardium. Muscles become hypoxic and can no longer function efficiently. When this evolves into MI or myocardial infarction, muscle cells die or are damaged, leading to inefficient pumping effort. Then, we also have cardiomyopathy, which is a disease of heart muscle that leads to an enlarged heart and eventually to complete muscle failure and death. So this can occur as a result of a viral infection, alcoholism, anabolic steroid abuse, or a collagen disorder. And it causes muscle alterations and ineffective contraction and pumping. Next, we have is hypertension that leads to enlarged cardiac muscle because heart must work harder than normal in order to pump against the high pressure in arteries. So that puts constant increased demands for oxygen on the system because heart is pumping so forcibly. Then, the valvular heart disease. So this leads to overload of ventricles because valves do not close tightly, allowing blood to leak backward into the ventricles. Overloading leads to muscle stretching and increased demand for oxygen and energy as heart muscle must constantly contract harder. So this is seen less often today owing to the success of cardiac surgery and effective treatment for rheumatic fever. So the end result of all of these four conditions aforementioned is that the heart muscle cannot pump blood effectively throughout the vascular system. If the left ventricle pumps inefficiently, blood backs up into the lungs, causing pulmonary vessel congestion and fluid leakage into the alveoli and lung tissue. In severe cases, pulmonary edema, which is manifested by rales, wheezes, blood-thinning sputum, low oxygenation, and development of a third heart sound can occur. If the right side of the heart is the primary problem, blood backs up in the venous system, leading to the right side of the heart. Liver congestion and edema of the legs and feet reflect right-sided failure. Because the cardiovascular system works as a closed system, one-sided failure, if left untreated, eventually leads to failure of both sides, and the signs and symptoms of total heart failure will occur. Okay, we now continue with compensatory mechanism in heart failure. Because effective pumping of blood to the cells is essential for life, the body has several compensatory mechanisms that function if the heart muscle begins to fail, as shown in figure 42.2 reflected in this slide. So the decreased cardiac output stimulates baroreceptors in aortic arc and the carotid arteries, causing a sympathetic stimulation. Sympathetic stimulation causes an increase in heart rate, BP, and rate and depth of respirations, as well as positive inotropic effect. So meaning there is increased force of contraction on the heart and an increase in blood volume through the release of aldosterone. Decrease in CO or cardiac output also stimulates release of renin from kidneys and activates RAS or the renin-angiotensin-aldosterone system, which further increases the blood pressure and blood volume. If these mechanisms work effectively, compensation is occurring and the patient may not have signs and symptoms of heart failure. Over time, however, all of these effects increase the workload of the heart, contributing to further development of heart failure. Eventually, the heart muscle overstretches from the increased workload and the chambers of the heart dilate secondary to the increased blood volume that they have had to handle. This hypertrophy or enlargement of the heart muscle, called cardiomegaly, leads to inefficient pumping and eventually to increased heart failure. The cellular changes and clinical manifestations of heart failure. Okay, for cellular changes, myocardial cells are changed with prolonged heart failure. Cells of failing heart seem to lack the ability to produce energy needed for effective contractions. Movement of calcium ions into and out of cell is no longer effective, leading to further deterioration because muscle contracts ineffectively and is unable to deliver blood to the cardiac muscles. For clinical manifestations, the patient with heart failure presents a predictable clinical picture that reflects not only the problems with heart pumping but also the compensatory mechanisms that are working to balance the problem. Radiology, ECG or electrocardiography, and direct percussion and palpation help to detect changes in the heart muscle and function. The heart rate will be rapid, secondary to sympathetic stimulation, and the patient may develop atrial flutter or fibrillation as atrial cells are stretched and damaged. Anxiety often occurs as the body stimulates the sympathetic stress reaction. Heart murmurs may develop when the muscle is no longer able to support the papillary muscles that support the valve leaflets or the annuli that anchor the heart valves. Peripheral congestion and edema occur as the organs and vessels become engorged, waiting for blood to be pumped through the heart as a result of pump failure. With right-sided failure, there is enlarged liver, or we call that in medical term hepatomegaly, enlarged spleen or splenomegaly, decreased blood flow to the gastrointestinal tract, causing feelings of nausea and abdominal pain, swollen legs and feet, and dependent edema in the coccyx or other dependent areas with decreased peripheral pulses and hypoxia of those tissues. In addition, with left-sided failure, edema of the lungs reflected in engorged vessels and increased hydrostatic pressure throughout the cardiovascular system, which is shown in the figure. Okay, take a closer look into the figure shown in the slide. Okay, so we go first with the left side heart failure. So as mentioned, the left side heart failure reflects engorgement of the pulmonary veins, which eventually leads to difficulty in breathing. Patients complain of tachypnea, so that is rapid shallow respirations, dyspnea, or there will be that discomfort with breathing, often accompanied by a panicked feeling of being unable to breathe, and orthopnea or decreased, increased difficulty breathing when lying down. No? So that is orthopnea. So the orthopnea occurs in the supine position when the pattern of blood flow changes because of the effects of gravity, which increases pressure and perfusion in the lungs. Orthopnea is usually relieved when the patient sits up, thereby reducing the blood flow through the lungs. The degree of heart failure is often calculated by the number of pillows required to get relief. Like for example, 1 pillow is enough to relieve the breathing problem, or 2 pillows or 3 pillows. So that is why we note it as 2 pillow orthopnea or 3 pillow orthopnea. So the patient with left-sided heart failure may also experience coughing and hemoptysis or coughing up of blood. Rales may be present also, signaling the presence of fluid in the lung tissue. And in severe cases, the patient may develop pulmonary edema, which can be life-threatening because as the spaces in the lungs fill up with fluid, there is no place for gas exchange to occur. Okay, we go into right-sided heart failure. So the right-sided heart failure usually occurs as a result of chronic obstructive pulmonary disease or COPD or other lung diseases that elevate the pulmonary pressure. It often results when the right side of the heart, normally a very low pressure system, must generate more and more force to move the blood into the lungs. It is also commonly occurs with aging, when the venous system fails to deliver blood to the heart effectively and the hydrostatic pressure in the venous end of the capillary increases, leading to a loss of fluid in the tissues and changes in the overall efficiency of the vascular system. In right-sided heart failure, venous return to the heart is decreased because of the increased pressure in the right side of the heart. That causes a congestion and backup of blood in the systemic system. So jugular venous pressure rises and can be seen in distended neck veins, reflecting increased central venous pressure. The liver enlarges and becomes congested also with blood, which leads initially to pain and tenderness and eventually to liver dysfunction and jaundice, if it is not managed. Dependent areas develop edema or swelling of the tissues as fluid leaves the congested blood vessels and pools in the tissues. Pitting edema in the legs is a common finding, reflecting fluid pooling in the tissues. When the patient with right-sided heart failure changes position and the legs are no longer dependent, for example, the fluid moves back into circulation to be returned to the heart. That increase in cardiovascular volume increases blood flow to the kidneys, causing increased urine output. This is often seen as nocturia, which is excessive voiding during the night, in a person who is up and around during the day and supine at night. The person may need to get up during the night to eliminate all of the urine that has been produced as a result of the fluid shift. So these are the treatments for heart failure. So actually, we have several different approaches used to treat heart failure. This chapter focuses on the cardiotonic drugs, which are also called inotropic drugs, that work to directly increase the force of cardiac muscle contraction. Other drug therapies used to treat heart failure include the 3 drugs classification reflected in the table. So for that, we have the vasodilators, the beta-adrenergic antagonist, and the human B-type natriuretic peptides. So the rest of it, I will leave it up to you to look closer when you are to get a PLP for this chapter. So you have there the drugs in focus, which is drugs we call cardiotonic agents. So these are actually drugs that affect the intracellular calcium levels in the heart muscle, leading to increased contractility, and that increase in contraction strength leads to increased cardiac output, which causes increased renal blood flow and increased urine production. Increased renal blood flow decreases renin release, interfering with the effects of renin-angiotensin-aldosterone system or RAS, and increases urine output, leading to decreased blood volume. So the result is a decrease in the heart's workload and relief of heart failure. So, our cardiac glycoside, so they were originally derived from the foxglove or digitalis plant, and these plants were once grouped up to make a digitalis leaf. So today, digoxin is the drug most often used to treat the heart failure. So you have there its therapeutic actions, indications, pharmacokinetics, and then the contraindications and cautions. Okay, I would just like to make mention for our therapeutic actions that the overall effect of this drug is a decrease in the myocardial workload and relief of heart failure. So digoxin has a very narrow margin of safety, meaning that the therapeutic dose is very close to the toxic dose. So extreme care must be taken when using this drug. So kindly take note on the adverse effect of this digoxin drugs. Okay, so you have there the adverse effect, drug-to-drug interactions, and drug-food interactions. Then the nursing considerations, diagnosis and planning, the implementation with rationale, and then the evaluation. Okay, for comfort measures, I would like to make mention that small frequent meals to help alleviate GI upset or nausea is recommended. Access to bathroom facilities if GI upset is severe, and to accommodate increased urination related to increased cardiac output. Safety precautions should also be provided to reduce the risk of injury secondary to weakness and drowsiness. Adequate lighting to accommodate vision changes if they occur, and positioning for comfort and frequent rest periods to balance supply and demand of oxygen. So for the patient teaching, we have to include the name of the drug, the dosage, prescribed technique for monitoring pulse and acceptable pulse parameters, dietary measures if appropriate, measures to avoid adverse effects, warning signs of possible toxicity, and need to notify healthcare provider, and the need for periodic monitoring and evaluation, including ECGs and laboratory testing. That is to enhance patient knowledge about drug therapy and to promote compliance. Then we also have the phosphodiesterase inhibitors, okay, which belong to a second class of drugs that act as cardiotonic agents. So that includes the inamrinone and milrinone. So kindly go closer or look closer into these slides. Okay, I would just like to make mention under nursing considerations that very important for us to assess for contraindications or cautions like any known allergies to the drugs, okay, to avoid hypersensitivity reactions. Then the implementation with rationale together with the evaluation. And then another drug we have is the hyperpolarization activated cyclic nucleotide gated channel, or the HCN blockers. Okay, so I will leave it up to you to study more. So that will be part of your independent learning required by CMO 15, which is all about your curriculum. And that is the end for this chapter. Thank you for your attention.